We'll just give it another 1 minute or so. For anybody who is new on this, please utilize the chat feature throughout this thing. If you've got questions, particular time, we are always going to leave time at the end for questions. It'll run for roughly an hour. Tonight's topic is going to be all things thyroid. Tons to say about it. So we're going to really pick this topic apart. This piece of anatomy that creates a whole host of issues for tons of reasons, and lots of mismanagement that exists out there on it. But we're going to get going. Starting off, we're getting a little more refined in terms of how we do this. So we tried to structure this in a little bit of a different way, get an outline in place, and really know what each one is going to be covering in some specific ways. And as I said at the beginning, we'll leave time for questions and answers at the end, so please make sure to do that. And I've said this before, but for anybody new as well, share this with friends, family, doesn't matter. They don't have to be patients of ours or somebody who's currently under care at the clinic. We just want to help get education out there on health topics and be continuing to educate that. I mean, doctor means teacher. We all love, that's what connected Dr. Mike and myself in a lot of ways. You know, we really resonate on our ability and desire to be helping teach and coach and educate our patients on how to do that. And obviously Ash does the same thing through her books and social media content, et cetera, which I know some of you have found her that way. So we're going to dive into thyroid here. I'm going to get started.
Kevin, can I interrupt for 1 second? He's ready to rock and roll. I like this. The energy is good, huh? Well, listen, guys, I just wanted to take a brief minute to do a couple things, just to make quick comments, okay? Because obviously we're getting inundated out there. Kevin and I are going to do a Facebook Live tomorrow, trying to update a little bit more about COVID, give you a little bit more insight, some of the things that we've recommended. Some of it's going to be redundant because everything that we've been saying all along is holding true. So I will say that I'm pretty proud of the fact that the things that we have commented on, even Kevin, 4 weeks ago, some of that is still holding true and being scientifically proven. So you're going to hear all this kind of stuff going through. So let me just quick things. Number one is Kevin made a comment last week, and I can't agree with him more. We have a pandemic of the virus, the SARS-CoV-2 19 virus, and we also have a pandemic of fear. And we've got to start learning to get that out of our system, reject fear, okay? Do that spiritually, do that mentally, do that physically. You got to do this. Shut off the darn television, stop watching the news constantly. They're out there to sell a product. I was watching, and it seemed like there was more commercials for the stupid thing, and it was a little blurb about something bad. Anyway, the fear I'm concerned about is now you're seeing that they're all worried about a second wave in the fall and what this is doing. Just remember that what they're talking about is we will not have a vaccine. We may not even have truly a supply of medicine at the time. So what they're concerned about having a mingling of both influenza and COVID disease at the same time. And that's, again, it's something that is a potential, but I don't want you to fall into fear about it because we've got 6 months before that even needs to come. We still don't know what's going on with the testing. Is the antibody testing going to show immunity or not? Hopefully it does. I mean, how many times have we talked about other viral infections where once you show immunity, you're immune for life? So, this is a unique virus, and we have to take that in consideration. Number two is the testing. So Quest just announced that they're going to have an antibody test. It's going to be rapid response. LabCorp is working with Roche. Quest is working with Abbott. They're all going to have that. What question is whether or not that antibody test is just going to show antibodies and exposure to the virus, or is it going to confer immunity? And that's something that we'll find out over the next 3 months. But That'll be before all this stuff in the fall. So don't start freaking out about second waves and all this kind of stuff. You got to live your lives. Don't live in fear. Okay. Three. So I can't count, can I? I said this before. Number three is you're seeing a lot of stuff out there being printed about the ACE2 receptor. And there's concerns about people that take ACI inhibitors, medicines for blood pressure. So you already know that hypertension is a risk factor for developing COVID disease, okay? Please do not stop your medicines that are ACE inhibitors and ARBs, okay? There was some media people out there telling people, oh my God, it hits the ACE2 receptor. So if you're on an ACE inhibitor, and there are thousands and millions of people on those, that they're telling them, media people, they're telling them, creating more fear to stop taking their medicine. Then their blood pressure goes up and oh my God. Now, number two is really the real studies are showing that those medicines are probably protective rather than negative for this. So it's the same way that ACE inhibitors are protective locally for the kidney to help the blood flow better, so it causes a vasodilation. We want those medicines to keep the vasodilation because part of what this SARS virus does is by raising angiotensin 2, it causes a vasoconstriction. So you've probably been seeing these dermatologic things where people look like they have frostbite toes and stuff. That's probably microangiopathic disease from vasoconstriction. So please don't stop your blood pressure medicines. Keep that under control. Don't fall into the fear of the media. Let's talk to a professional, Kevin, Ashley, myself, whoever your regular primary care doctor is, etc. I mean, I just want you to realize that. And fourthly, and the last one is the same thing we said before. Hydroxychloroquine is not a panacea. Okay, I am a Republican and I support Trump with a lot of things. Okay, I'll just say that. Although his Twitter drives me crazy, and I don't agree with his proponents of hydroxychloroquine. Hydroxychloroquine is a good medicine in the right spot, but it is not something for everyone. For a lot of people out there, hydroxychloroquine causes bone marrow suppression, which is going to lower your white blood cells and lower your infection fighting ability. And also hydroxychloroquine prolongs what they call the QT interval, which is an area on your EKG that gives you your relative refractory. And if you prolong that, then you can set yourself up for very rapid heart rhythms that can actually make your heart stop, okay? So no hydroxychloroquine. Don't fall into the fear. Hydrate, hydrate, hydrate. Supplements like Kevin has talked about. Wash your hands. Stay away from your face. Okay, that's it. Thyroid. Now on to your regularly scheduled program with Dr. Kevin Turner.
Exactly. So we're hitting
Facebook tomorrow.
Yeah, Facebook Live tomorrow. We'll talk about more stuff with COVID and give some other updates, talk about some other interesting data that has been coming out. But tonight is thyroid. And so we're going to start off talking a little bit about thyroid physiology, because at the end of the day, if we're going to talk all about a gland, we need to have a basic understanding of how it works. Doc, do you want to let them in there? So at the end of the day, we're going to start off. The thyroid, it's a butterfly-shaped gland in your neck, okay? So it's sitting in the front of your neck there, butterfly-shaped gland. Here's how it works. So if there's a stimulus in the body, let's say that you're cold. We're going to use that as an example. If you're cold, your hypothalamus in your brain goes and it talks to the pituitary gland in your brain. And so a signal is passed on and a hormone is released called TRH. TRH goes from the hypothalamus to the pituitary gland, and the pituitary gland releases TSH, or thyroid stimulating hormone. Thyroid stimulating hormone comes and talks to your thyroid gland, and it asks the thyroid gland to make a couple of things, okay? I normally draw this out on a whiteboard for any patients of mine. Many of you have seen me draw some of this out, but the thyroid gland makes T3 and T4. Now, T3 is considered the most metabolically active form of thyroid hormone. Now, that's only about 7% of what the thyroid gland actually makes. The other 93% is T4, okay? When we classically go to our most primary care doctors, a lot of doctors are just going to test the TSH coming from the pituitary gland to determine if the thyroid gland is healthy or not. We can maybe hear right off the bat with that might give a little bit of maybe a false impression of exactly how the thyroid gland is doing, because we simply are testing there a hormone that is telling the thyroid gland to do a job. Plenty of people have thermostats in their homes, and plenty of people have then a furnace that it's hooked up to. Your thermostat might be working just fine, and your furnace could be dead, vice versa. And so we've got to look at both components of this system here, okay? And so we've got T3 and T4 that the thyroid gland makes. Now, we said the T3 is 7% roughly of what the thyroid gland makes, and hormones don't just magically get to the cells in your body. They have to be carried there on a protein. And in this particular case, it's thyroid binding globulin. It's a globulin or a protein that binds to the thyroid hormone and carries it kind of like a truck to the cells. When we test hormones, we look at both free fractioned hormones and total hormones. If you've got a cell sitting over here and you've got a hormone over here that needs to be transported on a truck is way too big to get into the cell. So if the hormone is stuck on the truck, it's really not doing any good. It needs to be carried on the truck, but then it has to be let off, okay? I'm trying to give word pictures here so it makes a little bit of sense. So we've got this, it's making hormones, a couple of different ones, T3, T4, it has to be transported to cells. We look at free hormones. Free hormone is the hormone that is not on the truck. It's off of the truck. It's available to get into the cell. The total hormones is looking at what's on the truck, what's off the truck, okay? So that's kind of the story. Proteins carry it. We've got hormones, T3 and T4. Now, when you have a lot of T4, it has to get converted into T3. This process happens in the liver, in the muscles, nerve cells, a lot of different structures in the body, okay? And these processes are dependent upon a lot of nutrients being able to happen. If your liver isn't healthy, if you've got gut challenges, which I'll talk about in a second, you're not going to necessarily be able to adequately convert T4 into T3. Now, T4 gets changed, like I said, directly into T3, but it also gets channeled into a couple of other pieces. It gets taken into reverse T3, and it gets taken into T3 sulfate and acetic acid. Now, for the sake of kind of our argument here, reverse T3 is not going to be an active form of hormone that your body can use for anything. Conversion of T4 into reverse T3 is dependent on selenium. Conversion of T4 into into T3 is dependent on selenium, serotonin, dopamine, iron, zinc, whole host of different nutrients that if you're deficient in them, you're not going to be able to adequately convert T4 into T3. And then the T3 sulfate and T3 acetic acid that is also formed by T4 can, in a person with a healthy gut, get converted into T3 still for the cell to use. T4 also creates something called free T4, which is really it's about, from what the evidence shows in the literature, about 0.03% of the total T4 that is produced in your body. So a lot of times doctors will run a TSH with a reflex. So if TSH is out of lab range, it'll take it and look at also what's happening with the free T4. Correct me if I'm wrong, Doc, but
no, you're right. And then the other thing just to comment is that there's that negative feedback loop. So don't forget about the T4 level. Also, then go back some reflect, and that's why that reflexive T4 is what you're talking about. So yeah. Go ahead.
So that comes back up. So, you know, at the end of the day, the brain is talking with the thyroid is working with a lot of other organs in the body, all trying to get thyroid hormone to your cells. Now, every cell in your body needs thyroid hormone to function. Without thyroid hormone, you're dead. Someone has their thyroid removed, they are on thyroid medication for the rest of their life. It is essential for function. Now, the thyroid hormone receptors are found on the DNA of the cell, and it is a vitamin A dependent receptor. So if you're deficient in vitamin A, that can impact that thyroid metabolism and function as well, of being able to even get the thyroid hormone into the cell appropriately for it to do its job. Okay, so the thyroid needs a number of different components within inside of it as well in order to function: iodine, tyrosine, TPO enzymes, a number of other factors to make that thyroid hormone. Okay, so that's giving you some of the key players in the game here, but we also have there's lab ranges for these. And TSH, the thyroid stimulating hormone coming from the pituitary, talking to the thyroid gland, classically on most lab ranges is 0.45 to 4.5. You are not diagnosable with hypothyroidism unless that TSH number is lab high. That means above 4.5 in most cases. Now, lab ranges are derived in many different ways, but the TSH lab range, that range has classically been beat up by doctors because a lot of the studies that were utilized to derive that range would argue that it was skewed way higher than what it should be because of patients who were included in those studies with known and diagnosed hypothyroidism that was untreated. And so arguably that range has been skewed way higher. So if, for example, if someone comes in to see me and their TSH is 4.4, that might be okay and it might be normal. But I want to love where all of their thyroid hormone numbers are at. Their T3, their T4, their free T3, free T4, reverse T3, T3 uptake. We need to know where a lot of these markers are in order for me to feel really comfortable from a functional medicine perspective with where their lab ranges are at. And the same thing comes with the other thyroid hormones. You know, free T3, in my world, an optimal range is really 3 to 3.5. And someone can come in and they're at 2.5 and it still is lab normal. To me, it's getting a bit light because that's really what the cells are wanting to be using. Same thing for total T3. I think a lot of the ranges, it's like, Doc, help me out here, 79 to like 170-ish.
Yeah, it goes up to about 160, 170, depending. And Quest can be different than LabCorp too. You know, they have standards that they use, and so that's why they put those reference ranges over on the side, depending on what their reagents are. And just to confirm what you're talking about too, TSH is, you know, the TSH is a really tough number because it's also to some degree age dependent. So there are some variations, just like we talked last week about growth hormone being different. There's also some age dependence that change in that. I mean, one of the best things, and Kevin, you're absolutely right. You want to get as much data when you're trying to treat somebody as possible. But one of the best things still is going to be, you know, the caveat, you know, you treat the patient, not the numbers. The numbers are there to be supportive of what's going on. You listen to the patient and you take that stuff and you put it all together. So that's why when you say these ranges, you know, you kind of have to be a little careful with that stuff.
Yeah. And so, you know, there's my world, and we talked about this last week with the fasting and some of the blood sugar pieces, if we've got a big range, I like to shrink that down. Not just me, functional medicine doctors as a whole like to shrink that down, really narrow the range and allow buffers on either side. And once again, like you were just saying, Dr. Mike, listen to the patient. Someone's coming in, they're always cold, they have constipation, their hair's falling out, their skin is dry and scaly, they're gaining weight, they're having other, thinning on the outer third of their eyebrows, low energy, always fatigued, getting depressed and anxious. Like, I'm sorry, you're a classic hypothyroid patient at that point, and we need to explore that. And that's when we talk about thyroid problems, oftentimes we are talking about hypothyroidism or underactive thyroid, because that tends to be far more prevalent than hyperthyroidism, which is a very real thing as well. It just doesn't tend to be as prevalent as a hypothyroid situation. But that's a little bit of the basics of thyroid physiology. The brain is talking to the thyroid gland produces hormone, goes out into all the cells, and there's a lot of different areas that it can break down. And classically, people are coming in to the office on a routine basis saying, yeah, my thyroid's normal, and I look at their labs that they hand me, and the only thing that's been tested was a TSH, and it's at 4.3, and they've got all the markers filled out for having classic hypothyroid symptoms. And I'm like, it's not normal. And I don't even have enough data here to be able to look you in the eyes and tell you that your thyroid is functioning optimally.
I think that's an important point to reference here. When you talk about conventional medicine, typically runs 1 or 2 markers on the thyroid.
Typically about 10 markers.
Yeah. And what do we do? 10?
Roughly that I run on right out of the gate. And I'm not saying that's right, but in a lot of the functional medicine training and talking with lots of other practitioners, typically doing 10 markers is going to allow me to sit across from a patient and say, hey, I feel really confident about what may be breaking down in terms of thyroid functionality here.
Well, I would agree with you guys both. I think I'll say this. In the general medicine world, most of the times the routine screening, physical exam types of lab work that we do is a CBC, a CMP, which is comprehensive metabolic profile, and typically it's just a total T4. That's it, not even the TSH. And so that kind of opens the door up for exactly what you're talking about. So again, treating the patient, not just the numbers. Just because your lab work all comes back normal, if you've got all these other symptoms and you look and you smell and you walk like a horse, you're probably a horse and not a zebra. So you got to make sure that you follow up on those other specific tests, and that's really where a good clinician is going to be able to do that too. Okay.
Yeah. Agreed.
And then there's other tests too. I mean, there's other things that play into it. I'll say this. You're absolutely right. Hypothyroidism is probably much more prevalent. And a lot of times it's actually because misdiagnosed, okay? But the other big thing is that most hyperthyroid patients will burn out their thyroid and then they will become hypothyroid afterwards, okay? So whether that's through treatment or it's just they have early Hashimotos where it's attacking the thyroid and they're hyperthyroid initially and then the thyroid just burns out, then it becomes hypothyroid. Yeah, so there tends to be a little bit of a progression from the two. There's not as many pure Graves' disease people. Graves' disease is something where you're just hyperthyroid as compared to what you're talking about. So yeah, I mean, you have to, again, watch your clinical suspicion and know the other studies that go into it, and don't just be satisfied if your doctor says, well, your T4 is normal, so you must not have thyroid problem. Okay, time out. Now think about it, okay? Yeah. And then we started to talk a little bit. I'll just extrapolate a little bit more. Is there's other studies. Obviously, there's antibody studies that play into it a little bit to help you fine tune things. You talked about the peroxidase, the thyroid peroxidase antibodies, etc. But also, when you come into my office, a lot of times the physical exam is such an important part. And it's glad you pointed out where the thyroid is. In men, it's just under the Adam's apple because of the the larynx cartilage right up there, etc. And the bottom part of the butterfly actually goes just underneath and around where your clavicles are, where your collarbones are. So sometimes it's very hard to even appreciate it. So a lot of times we will palpate the gland, and that can clue you in. Sometimes it's pulsatile, sometimes it's hot, sometimes the artery flow is increased, etc. And that clues you too. So those all are other factors. And then that brings up the other tests like ultrasounds. Okay, I feel something on one side as compared to another side. One side is more large. Oh boy, that's terrible English. It's bigger than the other side. Okay, and is it just a goiter? Is it an iodine deficiency and just a diffuse infiltration from not enough iodine and having a big goiter like we always used to see on National Geographic with the poor people in Africa, etc.? Or is it a multinodular goiter where there's all kinds of nodules? Well, that's where the ultrasound comes in. The ultrasound can help guide you to say, is it fluid filled? Is it solid? Okay.
Yep.
Thyroid cysts are just about as common as breast cysts. It's a glandular gland. Oh my gosh, I'm terrible tonight. Anyway, you get the idea. Okay, so it's secreting hormones and it's getting into the bloodstream. So an ultrasound helps guide you to see whether or not it's a cyst or it's a solid. Is it a nodule? Is it a multiple nodule? Ultrasounds are good to diagnose thyroid cancer if the person has adenopathy, they have lymph nodes along with it, and so there's some telltale signs that way. But for the most part, if you've got a nodule, then you need to find out whether or not it's what they call hot or cold, okay? And that's basically done with a radionuclide scan. So something in the nuclear medicine area where they give you a little bit of a radionuclide dye, and then that either shows that it's hot, which unfortunately usually means that it's a cancer because it's hypermetabolic. I mean, you just even said the thyroid gland itself is your basal metabolic driver. So if you've got a hot nodule, boy, you can imagine what that is. And that will mimic some of the signs of hyperthyroidism, and it needs to be treated in a different way. So that radionuclide scan will then guide you, is it a hot nodule or a cold nodule? And if it's a cold nodule, there are some people that will use thyroid replacement to slow down the stimulation to the gland, but that's another thing when we talk about treatments and stuff. But those are pretty much the main all other types of modalities that you're doing when you're doing thyroid functions.
Yeah. When it comes to management of thyroid challenges, I was talking with patients today about some of this, and you and I have had many conversations about it. From my experience working with patients with thyroid issues, which there's a ton out there, I'm not sure where it ranks in terms of autoimmune challenges and things like that, but Hashimoto's and other autoimmune challenges against the thyroid gland, the prevalence is super high. And it seems like the common approach in most medicine is, here's levothyroxine or Synthroid as the medication. Like, do you want to speak a little bit about, there's differences in medications is what I want people to understand here. It's not a one size fits all.
Here we go back to treat the patient, not the knee-jerk reactions. So it's certainly much easier for regular doctors to prescribe Synthroid or levothyroxine. There was other one, Levothyroid. There's a couple of them out there, and because they are synthetic, they're easier to manipulate and watch the numbers when you use a T4 replacement with the TSH. So that's a lot of times you go to the doctor and they give you some replacement, and then they look at the numbers and the numbers look good, and that's that. Well, that's not the whole picture, just like Kevin was really saying too, because there's such a big conversion. there's also other medicines that play into it. If you're on a birth control pill, it's going to raise your T4. If you're iron deficient, you even talked about with some of the other nutrients and minerals that play into it too. So it's just easier. I'll say it. It's just easier to use Synthroid, and for the most part, it's typically more available. We've had a couple of circumstances where there was a shortage, but that's that. But as Kevin said, T4 is not the biologically active molecule. So T3 replacement is really going to get more bang for your buck. How's that? Okay. And there's versions out there. There's something called Armor Thyroid. There's Unithroid, that's a T3 replacement. There is Westhroid. There's several of them out there. Nature-Throid, etc. The problem is that a lot of pharmacies don't stock those, okay? And it's because so many doctors use Synthroid rather than these things. And I think also the shelf life might be a little bit shorter. So, of course, it always boils down to dollars and cents in pharma, big pharma and stuff. So, when you're going into this, you want to make sure that you're not missing out on any nutritional parts. And I'm going to get Ashley to talk a little bit about that. And also, again, treating the patient. So levothyroxine and Synthroid can work for quite a few, like you're saying, normal ranges. Well, you're talking about that 2 standard deviation bell curve. What is normal? And then there's people that are going to fall outside that. Well, then start thinking outside the box too, and treat the patient with a T3 replacement, which is usually my personal go-to now, just from experience. But it's not necessarily how we are trained in medical school and in residency and stuff. And again, that's I think it's a failing. But so that's I think what you're asking about too.
Yeah. And I think that, at the end of the day, I was working with a patient today, and their TSH is totally fine. And they're taking they're taking levothyroxine, so synthetic T4 only product, and their free T3 are lab low and very lab low. And the medication is not working for them because there's no conversion that's able to happen for them right now. And there are being symptoms that remain.
Yeah. And like you're saying, you treat the whole person. What other things are going, what other stressors are going on? Are the cortisol levels high? What are the things that enhance that conversion? So why not go right to a T3 replacement? Well, then, the thing about thyroid tests, for the most part, especially TSH, is it lags behind clinical symptoms, okay? Sometimes upwards of 6 to 8 weeks. So even when you do manipulate and do some replacement, you have to wait a little while to look at those numbers. So that's why, again, you talk about how's the patient doing, what kind of symptoms are you feeling, and listen. I mean, that's such a big part of medicine.
If you're getting your thyroid checked, get your thyroid labs run same time of day, okay? Oh, yeah. And ideally fasting first thing in the morning, from my training, because there, as Dr. Mike was mentioning there, those numbers change throughout the course of the day. They change as you age. There's all kinds of variants that play into that, but try to be consistent in getting your labs done. Don't, go one time fasting first thing in the morning, then the next time go at, 3:30 after eating a massive lunch, and you're not going to be comparing apples to apples necessarily there at all.
And especially if you're on other medicines and things too. But yeah, that's a good point too, Kevin, is there's something called the dawn effect first thing in the morning. It's usually about 4 or 5 o'clock in the morning, get you up, get you going. And that's where your thyroid starts to get stimulated. That's where your cortisol levels, everything gets moving for the course of the day. So that's also technically where they're standardizing some of the lab results are based off of an 8 a.m., 12-hour fast. And so that's important. And then the other piece is always, always, always make sure you're taking your thyroid medicine on an empty stomach, okay? It needs that acid in order for it to get absorbed into your body. So, and then that also makes it a little bit more consistent with everything too, okay?
Exactly. Exactly. You know, when it comes to thyroid gland, there's, as we started to mention, there's a lot of autoimmune challenges that have to deal with that. I'm going to let Ash talk a little bit about that here, talk about what happens with that.
So a really important term to consider here is the idea of molecular mimicry. And the idea is, you know, when you look at our immune system is trained really to look for protein sequences, and in particular ones that are going to be foreign invaders, so to speak, to the body. And they're trained to look for certain protein sequences and tag them as dangerous and harmful for the body so that our immune system will then attack and get rid of those things. But sometimes what happens is, you know, we might have a chronic infection or a pathogen, and those proteins that are being attacked are maybe the outer surface of a virus or some other infection or pathogen that you might be having in your body. And so here we start making antibodies towards these protein sequences. And over time, as this happens, your body might start seeing other molecular sequences on various tissues within the body. So the molecular mimicry, those protein sequences, can be seen, so to speak, as the same thing. So, okay, we've got this virus here. We don't want it. We've tagged it as harmful and unsafe, and we're going after this protein sequence day after day after day after day. Oh, but you know what? That really looks like the thyroid gland, says the immune system. So we're going to start attacking this molecular sequence that just happens to mirror that of the virus in this circumstance. So this is molecular mimicry, but it's a mistaken identity really within the body, that we're going after the wrong thing. It's a, you know, the immune system is really a beautiful, well-oiled machine, but it's not perfect. And this is an example of how it can go awry. You know, for example, you know, a pathogen, Lyme disease, for example, has 16 different proteins that look identical to the proteins that are in the thyroid gland, Lyme. Yersinia, which is a bacterial infection, has 19 different proteins that are going to mimic the thyroid gland. Okay, so you can see how over time, you know, if you have a chronic Lyme patient who starts, you know, having hypothyroid symptoms, you know, that you can kind of see the picture here because of the body's immune reaction to, you know, what started as the pathogen and now is getting into a more far-reaching state here. So the thing that we need to also keep in mind is that foods also have the ability to have molecular mimicry. So a really important thing to consider if you have autoimmune thyroid or hypothyroid symptoms, even Graves' symptoms, hyperthyroid symptoms, is to look at gluten. Gluten, unfortunately, looks a lot like the thyroid gland. Very similar molecular sequencing here. So
it's a pretty universally accepted thing in the functional medicine world that gluten looks like the thyroid.
There's a lot of research out there. I wrote about it. There's 156 scientific reviewed studies here in my book. They're not all about gluten, but there is really great stuff and content in here to support this. So it's not just opinion. It is well backed by the literature. So again, you know, if you think about, you look at our standard American diet, gluten, 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 all day, every day. It's very, you know, the standard American diet is eating a lot of processed foods and often very high gluten. So after eating this you know, gluten initiates the release of zonulin in the gut, which opens the tight cell junctions and creates a leaky gut as well. So then, you're having these gluten molecules that actually get in, and if you have a leaky gut, straight into the bloodstream. And so the body sees those molecular sequences and, those aren't supposed to be here. Attack, the whole, immune system is going after these gluten molecules that are circulating around the bloodstream. We're attacking them. But then again, similar thing. Oh, that looks a lot like the thyroid gland. So we're going to now attack the thyroid gland. So again, really important to consider gluten if you have thyroid symptoms. But it doesn't stop there. Gluten, there's many foods that are cross-reactive with gluten, which means there's many foods that are going to be cross-reactive and look like your thyroid tissue. Casein, which is a protein in dairy and milk, is very similar in molecular structure to gluten. And the research shows that 50% of people that are sensitive to gluten and have immune issues with gluten are also going to have that to dairy products and the casein molecule. There's also a lot of other foods that are going to be cross-reactive. A lot of the gluten-free grains are actually still cross-reactive. Oats are a big one, corn, rice, millet, yeast. Those things are actually also going to be cross-reactive with gluten. Again, it's well published in the literature based on that immune reactivity there. So
nobody's run away yet. Nobody logged off and started talking about everything that can start to cross-react there. We did take it back. But
so it's also Ashley, if somebody is hypothyroid, or should they now also limit those types of foods? How's that?
Yes.
Yes, at least for a season. I can't think of any time that I would recommend a Hashimoto's patient to ever consume gluten. But, if you're kind of on the fence or you don't have a diagnosis and you just have some symptoms, that's, a huge piece of even what I wrote about in the book. Take it away for a season. You're going to know when you reintroduce it. If you remove, any trigger food, really, you remove it from your diet for a time being. Hopefully your symptoms are going to reduce or completely diminish. And then, you reintroduce that, and then all of a sudden your thyroid symptoms are a mess. It's a pretty telltale sign. Obviously, we have food sensitivity testing and things like that we can do. But, doing an elimination diet is free and kind of empowers you to make those decisions as well. But I do also want to say here, there's also something called the bystander activation. And I think it's important to talk about EBV, Epstein-Barr virus here, mono, very common virus that many of us have been exposed to. Lots of, symptomatology with, inflamed lymph nodes, sore throat, fatigue. So what we have found and what the literature really supports is this bystander activation, where the EBV really can kind of inhabit the thyroid gland. And what happens is the immune system senses that the virus is there, but also, as it's attacking this virus, the tissue gets destroyed as well. So it's not necessarily the same as molecular mimicry, but it's kind of, guilty by association because that EBV is here. So that is another big component, even to like a functional medicine workup. If you come in and you've got hypothyroid symptoms, we're probably going to run some EBV titers and see what is going on just from that standpoint, because again, there's this pretty significant link with, chronic.
There's some speculation as well that some of the nodulation that is so common and frequently seen on some of the ultrasounds, whatever, if that's not to an effect, some consolidation that could be occurring by the immune system. I'm not sure what research is out there on that, but I've heard many doctors from many different kind of background of training, medical doctors, other functional medicine practitioners who there's some thought about that towards it in the sense of this whole bystander activation piece and how the immune system is working to get at something that is taking up inhabitants there. And, you know, ultimately the thyroid gland can be getting destroyed because of the chronic immune response, whether it's due to molecular mimicry or to this kind of bystander activation concept.
I think just real quick, you know, we've talked about some other pathogens that, you know, might cause this bystander or the molecular mimicry, but we also have to look at what could be creating a leaky gut. You know, what is allowing, you know, really the gut to not be, you know, fully functioning and allowing food particles or pathogens into the bloodstream and causing other autoimmune issues too. So things like, you know, looking at candida, mold illness is really a significant piece here. H. pylori. I mean, the list really goes on, but, you know, just because you don't have EBV, that doesn't mean that there isn't some other infection or pathogen in there that could be driving some of this autoimmune or thyroid symptoms.
Let me make one other corollary to that too, like you guys are talking about. You know, a while ago, the other big thing for thyroid nodules, thyroid cancer was radiation exposure. So, you know, x-rays, whether they're dental x-rays, I mean, everybody gets shields and things like that these days, but that's also a big factor. And just like you're saying, EBV and CMV, which is another virus that tends to cause infectious mononucleosis like you're talking about. Don't forget, those things also cause liver and spleen involvement. And when we go back to what Kevin was talking about, where these proteins and things like that come from the liver. So there's also some antibodies that get induced, and then the molecular mimicry kind of hits up again too. So, you know, it's just very interesting how there's so many overlaps, things that overlap. The other big thing I'll make a push for is that, you know, it's always imperative whenever you see a functional medicine doctor or, you know, a traditional medicine doctor, et cetera, that you let the doctor know all the medicines that you may be on or all the supplements that you may be on as well. A lot of times I'll have patients that just got put on amiodarone for congestive heart failure by the cardiologist and are doing great. And they forget to tell me that they're taking this because they can't even pronounce it. And that has such a big effect on the thyroid. You know, beta blockers have an effect. So, lithium has an effect. So there's so many medicines out there. Estrogens, birth control pills, estrogens have an effect. So it's so important when, again, taking a look at the big picture and treating the whole patient, not just those simple things. It's always important to, you know, I know you always see the disclaimers, make sure you tell your doctor all the medicines you're taking, but, you know, a lot of times people do forget, and so it just plays into getting to know the whole person. So those are the other things too, but that was good.
Yeah. So that's kind of thyroid overhaul here.
I want to talk about some nutrition.
Yeah, I mean,
we do have questions that have been emailed.
I think one of the things that's an important thing to note here is that Dr. Mike had mentioned about goiters and iodine deficiencies and all. And to be honest, in the United States, that's a very rare thing. You know, Morton's table salt, it's that iodized table salt. It's what's included in pretty much every processed food that's out there. Iodine deficiency as a whole is very rare here. And a lot of people say, well, should I start supplementing with iodine? And one thing that's really interesting to look at is in countries where there's severe iodine deficiencies, when people are being supplemented with iodine, the rates of autoimmune disease in the thyroid glands skyrockets in that country. And so I think we need to make sure, bottom line, I always tell patients this, like, your body has to have the raw ingredients available to bake the cake. And so it needs iodine, it needs selenium, it needs tyrosine and the TPO enzymes and zinc and iron and serotonin and dopamine, which are neurotransmitters in the body. And, it needs all of these kind of component ingredients in order to make and convert the hormones effectively for the body to play a role. And it goes without saying, in all of these things, you have to be eating a nutrient-dense diet. Your body has to be able to break down, digest, and absorb those nutrients.
Which will not happen if you have a leaky gut.
It can't. And I know one of the questions was, can low HCl play a part of that? HCl for the hydrochloric acid that's secreted in our guts to help break down our foods. If we've got low HCl or hypochlorhydria, our body's capacity to break down food and to kill off pathogens that may inadvertently be ingested. I hate to tell you, but all your food is not sterile that you eat. That HCl is playing a role in breaking down the food, but killing off those pathogens.
And triggering enzymes to be released so that you can further break it down. I mean, it's a top-down process. If we're sitting down at our table completely stressed out, that's going to lower our HCl. So I'm like, the first thing you got to do is just sit down and take a deep breath, for crying out loud. Yeah.
So if those things are low, bottom line, if HCl is low, you're not going to break down your food effectively or efficiently. You're not going to kill off pathogens efficiently at all. And it's going to set you up to not have those raw ingredients available for your cells to do their jobs the way they would want to otherwise.
Well, my son's going to kill me, but I agree with you totally with this. Too much of a good thing is not a good thing. And the same thing was true. People might associate with fluoride. Fluoride is a halogen, just like iodine is. And for a long time, everybody had fluoride. There was actually fluoride supplements for the babies. And then you would get fluoride in the toothpaste, and then you started to develop fluoridosis, where the teeth were getting white demarcations and thickening, etc. So, you have to be careful about, oh, well, I got to add more iodine in my diet. That's definitely not the thing to do, nor the fluoride, too.
Fluoride is a potent neurotoxin. There's plenty of literature on that. But when it comes to iodine, like if you're concerned about, am I getting enough iodine in my diet? Eat some of those seaweed snacks that you can get at a health food store a few times, like seafood, sea plants especially are a fantastic natural source of obtaining iodine. Get it in your diet. You don't need to be spraying Lugol solution all over yourself or a lot of those other things. I think for the most part, that's an unnecessary step in most situations.
Yeah.
Yeah, focusing on nutrients like zinc and selenium are really huge for good thyroid function. Some of the raw ingredients that you talked about, vitamin A, vitamin D, making sure that you have the optimal status, not only for the thyroid, but just your overall immune function. And, if there is an autoimmune component, that's going to be hugely, modulatory for the immune system as well.
Iron, I want to say, I talked about iron is important for the conversion, but when I mentioned serotonin and dopamine, iron is also a critical rate-limiting step or cofactor in the proper production of those neurotransmitters. And so if you're anemic and it's not a bad anemia, you're always that way, it's normal for you. No, it's not. Anemia is not normal. Anemia is never okay. Get that fixed, okay? Get that looked at and understand what kind of anemia you have, why you have it, and get that addressed. If it's an iron deficiency anemia, get some iron into you. If you're a cycling female and your ferritin's a 6, it's not okay? Even if your hemoglobin is normal, I'm going to tell you it's not okay. Your red blood cells, hemoglobin, hematocrit can all be lab normal. If they're all on the low end and your ferritin's a 6, get some iron in you.
Yeah, and actually that's a good point, because low iron also tends to stimulate the chemical reaction from converting T4 to the reverse T3. And like you said, Kevin, reverse T3 is an inactive molecule. So not only are you going to get fatigue and all the other symptoms of the anemia, you're also going to have symptoms of hypothyroidism at the same time. So that's really important. I think there was somebody had a question once about having too much iron. And that kind of brings up the question of is that excess iron also having higher levels of ferritin and actually a pathologic condition called hereditary hemochromatosis, okay? So you kind of need to look at that first, because that has more of a liver effect, yep. And then just like you're talking about with these other things. So if it is hemochromatosis, yeah, fine. I think most labs now won't even let you donate. American Red Cross won't let you donate. You'd have to go to a hematologist to donate blood because of that illness. So you do need to get that down. But more importantly, you got to make sure you're not developing liver fibrosis, which then can go on to liver cirrhosis, etc. But again, it has a direct effect on liver metabolism, and that's how it's going to have an effect on all this stuff too.
Yeah.
We had another question about how high thyroid antibodies need to be in lab results to determine hypothyroidism versus Hashimoto's.
So explain, I'm just going to say it one more time so it registers to me. Explain how high the thyroid antibodies need to be in the lab results to determine whether a patient has hypothyroidism versus Hashimoto's thyroiditis. So hypothyroidism is only I don't care if your TPO antibodies are 1,526. I can't say you have hypothyroidism because hypothyroidism is only the diagnostic criteria is lab high TSH.
You probably have preclinical hypothyroidism. In other words, it's probably going to happen. But that doesn't by itself create the symptoms of hypothyroidism. Your T4 has to be down, and all the things that we just talked about, those things have to be down. It's not the antibodies. There's something called postpartum hypothyroidism. I don't know if anybody's ever heard of that or not, but it's a transient thing that is pretty common right after having a baby. And some of it has to do with getting some of the baby's T4 into the maternal circulation, which then auto-regulates the TSH to say, hey, what's going on here, and throws everything off. But it's also because of the mixing of some of the antibodies across the placental barrier. And that's transient. So that doesn't necessarily mean that that person's going to be hypothyroid all the time. And just like this, the antibodies don't necessarily mean that you're going to have hypothyroidism, but it sure sounds like that's the way it's going to be going.
Well, I always tell patients this: you've got, a ton of bullseyes that have now essentially been painted on your thyroid gland, and it's a matter of when something's going to hit that bullseye. Yeah. So it has been targeted. Your thyroid has essentially, for simplicity's sake here, been identified for destruction by your immune system. And it's kind of a ticking time bomb that may never, ever go off. But if your TPO in this, I'm going to say thyroglobulin, TPO in particular, antibodies are lab high, it's a ticking time bomb that way for a potential immune attack against your thyroid gland, where the thyroid gland will begin to be destroyed inadvertently by the immune system. And
I think it's important, a lot of times autoimmunity is there's a triggering event, whether it's a time of intense stress, a traumatic brain injury, you were exposed to EBV, or you got a tick bite and now you have chronic Lyme. Like there's typically a triggering event that makes the autoimmune cascade happen. So again, if you have high antibodies, and you do have a triggering event, that's typically what can kind of trip the switch, so to speak.
Yeah.
What other
another question about HPA?
So that kind of, I think there was a couple of questions on that. So there was the one here from Kate. What if you have high antibodies but the other markers are in good range? Same thing. Keep your eye on it for sure, because in essence, there's a warning sign there's a warning light on the dashboard right now. Don't put a piece of tape over it and ignore it.
Kevin, Do you Kevin, do you automatically do autoantibodies when you're seeing somebody? Is that part of your routine? Because ordinarily, if your T4, your free T4, your T3, the TSH, all the things that we talked about before, if those are all normal, I wouldn't even bother to do the antibodies. But I'm just curious.
For myself,
yeah.
What I order on almost anybody when I look at thyroid, my initial workup is the TSH, the free T4, total T4, free T3, total T3. I look at the reverse T3. I look at T3 uptake. When I mentioned thyroid binding globulin, that transport truck, thyroid binding globulin is pretty unstable in the blood. We look at T3 uptake to give us a good idea of what's happening with that. And typically what goes along with that is free thyroxine index goes along with that. So it kind of gets thrown into the mix as another marker that's looked at. And then I look at the TPO antibodies and thyroglobulin antibodies. And the only reason why I run them on almost everybody is the prevalence of hypothyroidism, but also to just start to get an idea of if somebody has hypothyroid symptoms in the mix at all. I just like to know, are we looking at something that may be a subclinical hypothyroidism being driven by a potential autoimmune response, or is it maybe something else from a conversion standpoint or an underconversion standpoint, or a different primary hypothyroidism that's coming just from the thyroid gland isn't making enough of something for whatever reason?
Right. Okay. That makes sense. And it's not part of mine. I do all the other ones. And like you said, you get a free free thyroxine index, FTI, as part of what the lab does. But I don't usually do it unless I'm not usually doing the autoantibodies unless otherwise. But anyway,
I do. It's not right or wrong. It's just I like to throw that in. If they're going to be at the lab, we'll just do another vial.
And I could make an argument to, do some other gut repair and
it does like influence what nutritional recommendations I might make, because if I'm seeing the TPO antibodies being lab high, I'm going to say, you know what, we're pulling gluten for a while, just right off the bat. The gluten's gone. Let's start identifying a few other things here and see how we see those antibodies respond.
Even the antibodies that aren't lab high, I know Mayo Clinic says, their
range is small, like 0 to 9.
Small, so I think, 9,
but when it comes to that as well, if there's 100 different targets that have been painted onto the thyroid gland, and we can bring it down to 30, like it just is kind of starting to pull away targets almost. So. What other questions do we have here? I know we're kind of at that 9 o'clock-ish point here, but feel free to throw some questions along. I'm still good. I can't speak for you, Dr. Mike, but I'm good.
Questions here asking about linking low thyroid and adrenal. We had another email question about that as well.
So 2 of them. Okay. So I'll just say this, the hypothalamus, pituitary, thyroid, adrenal, gonadal, like the whole endocrine system, the whole hormone system, it's all tied together. We're a whole person, okay? And that's part of the challenge in healthcare is we've gotten so specialized that nobody's looking at the person as an entire entity anymore. And the HPTA-G axis, if one is off, oftentimes another portion is going to be off as well. And there are typically stressors that we've mentioned a lot of them here, whether that's infection or food sensitivity challenges or environmental toxins, et cetera, that might be driving thyroid dysfunction. They're stressors. Adrenal glands are producing hormones that are some of the big ones to help deal and combat with the stressors that we encounter. So supporting both is typically really beneficial, and one can beget a challenge in the other.
Yeah, I'd say that one question said something about adrenal fatigue after treatments, chemo, radiation, etc. You got to remember that the adrenal gland does multiple functions. The outer cortex has three big functions and then the inner medulla has all the adrenaline and with the sympathetic nervous system types of things. If you're having symptoms that are both hypothyroid and hypo adrenal cortical adrenal, usually your blood pressure is low as well because your aldosterone is low. Usually you have to start thinking, did this affect your pituitary gland? You go back up to the master gland that's causing both of those two things at the same time. Because typically, if the cortisol levels are high, then your thyroid kind of slows down. Your metabolic rate changes because of the two things. So there's a little bit of a balance. When you start getting both of those, then something else is going on, and maybe the chemo, maybe the radiation, maybe something like that. Stress levels have an effect more on your pituitary gland, causing that whole system to be sluggish too. But so again, it's individual. You have to really kind of look at each person individually.
Yeah. New question here. My endocrinologist keeps wanting to biopsy the nodule on my thyroid. 2 times the test came back inconclusive. Does it make any sense to keep monitoring and repeating the biopsy every 6 to 12 months? I think it is doing more harm than possible beneficial info. Ultrasounds have been stable over 3 years.
Actually, let me take that one because it was the one question that I asked about. I guess the question is have you had a radionuclide study to see whether the nodule is a hot nodule or a cold nodule? If it's a cold nodule, then typically you can monitor it with ultrasound. You keep repeating the biopsy, and you're also now traumatizing the tissue, and sooner or later you're going to get abnormal cells just because of the biopsy. So it's going to bleed. Anytime you do a biopsy, it's going to bleed into the tissue on the inside, and that actually stimulates cytokines, inflammation, etc. So I'm not trying to disrespect what your endocrinologist talked about. That is actually somewhat standard, but once you've gotten 2 negative biopsies, you should be able to just monitor it with an ultrasound, as long as it was not a hot nodule initially, and as long as you're not predisposed to medullary thyroid cancer, papillary thyroid cancer. There's a whole bunch of them out there, and certain medicines, some diabetes medicines are notorious for stimulating that too. Again, we bring back that the medicines play into it too.
Yeah, definitely. I totally agree. And I think, bottom line, it's a constant. If I keep flicking my thyroid gland, at some point, the thyroid gland's going to get cranky with that whole situation happening. And so if we are continuing to biopsy, that is ultimately, as you said, trauma. And so, yeah, I couldn't agree more with that. Right.
If you're diagnosed hypothyroid, how often is that?
Does the thyroid come back to working correctly?
Does the thyroid come back? What?
If diagnosed with hypothyroid, how often does it come back to working correctly? And I think my answer to that would simply be this. It depends on what's causing the hypothyroidism.
Yeah.
What is causing it, and how long has it been going on? If it's a matter of the pituitary isn't talking to the thyroid correctly, and we need to kind of re-stimulate the feedback loops and get some of that going, there's ways of doing that, and they might kickstart the whole process and you're good to go. It might be that you're on a medication for a few months and all of a sudden you find, hey, I don't even need these meds anymore because the meds kickstarted that whole process. Supplementing similarly can also do some of those things. But if you've been hypothyroid for 20 years and have been medication dependent for that whole time, et cetera, there's only so far that the body is ultimately going to recover from certain things, depending on length of duration and the ultimate why something began. And that's where I think it's critical to work with a doctor who's going to try to figure out the why behind a pathology or a disease process beginning in the first place.
The one thing we always say, and we have students in the office now too, I always tell them the less medicine, the better. So if we can stimulate things and get them to the point where you can be self-supportive, then that's obviously the way God wanted it. That's the way your body should be working. I made the comment about postpartum hypothyroidism. You can be hypothyroid because of just having a baby, and that is transient, almost always within 6 to 9 months, depending on whether you're nursing or not. That will get better as well. Sometimes you do need to use some medicine in that circumstance. Well, partly because you don't want to go crazy having a baby and being up all night, but there's circadian rhythms and all that kind of thing. I won't say anything else, but and also your body is going to start to repair itself, and then that support will get you over, and you won't need to do it anymore. So again, just like Kevin said, you got to find out the whys. The underlying pathophysiology is the key. It's not just one particular thing. Same like high blood pressure. Just because somebody tells you high blood pressure, hey, it might be secondary types of hypertension rather than essential hypertension, and so there are times when those medicines can even be discontinued if you figure out what the why is.
Absolutely, absolutely. Could you give general diet recommendations beyond gluten-free? Is there a specific diet that generally is helpful? Paleo, AIP, etc. I've got my thoughts. Do you want to?
I think that's, well, you guys segued into that nicely too, because it's kind of, what is it? If you have an autoimmune component, autoimmune paleo would be a fantastic fit. But
I'll say this, autoimmune paleo isn't for everybody either, and that's okay. All the components, cassava is totally cool on AIP, but you still might have immune reactivity to cassava as an example, okay? And so we need to still understand, you could be on an AIP diet and be totally fine with eggs still, even though that's not AIP compliant. So sorry, I interrupted, but I think everything. Go ahead. And what other thoughts? So AIP diet.
Yeah, I do think that's a good place to start regardless, though, because it's going to take the main triggering foods out. Now that's an immune triggering, but it's still, I think we all can, it resets the gut. It, lessens the inflammation within the body. It helps restore nutrient deficiency. So it's not just an autoimmune, not just helpful for those with autoimmune diseases. So I think, again, when you remove triggering foods, which would be gluten and grains, dairy, corn, eggs, soy, nuts and seeds, sugars, like the food additives and chemicals and things. Did I say soy?
Yeah, you did.
I think that's all of them. The big ones. So you remove those for a period of time, allow that inflammation to calm, allow your gut to hopefully heal some and, get really good nutrient dense foods so that you aren't nutrient deficient anymore, which many are who eat a standard American diet. Then you go and you add those foods back in, or you still don't have your symptoms rectified and we might need to pull a couple other things out. That's fine. That happens. But for the most part, people are oftentimes feeling much better. And then you go in and you add, and eggs are fine, but dairy gives me a headache and gluten makes me constipated and gives me my thyroid symptoms. Then you're just going to know, well, gluten and dairy are the big ones for you. And then it's really, that's like individualized care. It empowers you to make good decisions. Obviously, we love walking alongside of people.
And we can always pull in the testing, the immune testing as well, where we're looking at, IgG, IgM, IgA responses to different foods, different food additives and spices and you name it, and understand, is there immune reactivity that is truly unique to you? And we can start to tailor things that way as well.
Corn is in like almost everything. How do you get rid of that, huh? That's a tough one. That's a tough one. I did see something. Oh, the radionuclide study. Is the thyroid is hot or not? It's a hot thyroid, baby. There you go. It's just basically called a thyroid scan. It's a radionuclide scan of the thyroid. You do it in what they call the nuclear medicine area of the hospital. But basically, all you need to do is ask for a thyroid scan, not an ultrasound, but a thyroid scan, and the radiologist, when you do that, will give you a report about it. And again, it will tell you whether it lights up or it's just cold, see like a deficit. When it lights up, that means it's increased vascularity. That's got a lot of blood flow to it. There's a lot of activity. There's a lot of metabolism going on. Again, thyroid is the metabolic gland with everything. So if it's a hot nodule, that it's overactive, it's working too much, etc. And typically the person will have symptoms of hyperthyroidism, but even sometimes a cancer, you may have symptoms of a low thyroid disorder, and yet you'll have this hot nodule. So, it's catching a lot of press recently too, with all the stuff with COVID and things too. So,
any other questions trickling in here? Next week, we're going to probably be talking a lot about EMFs, or electromagnetic frequencies. And you might be like, who cares? Why does that matter? But there's a lot of talk that's starting to rumble about that. Some kind of prominent, well-known docs like Dr. Joe Mercola have written books recently on the topic. And there's a lot of potential health implications and, frankly, tons of research that exists out there on that. And so we're going to be starting to dive into the world of EMFs. That is one that I think you're definitely going to want to hear. There's a lot of info to discuss and a lot of important physiology to begin to understand how this can impact so many of, frankly, even the health issues that our nation is dealing with right now and as a whole. So that's what we're going to plan to talk about next week. Same time, same channel.
Series is coming on that as well. And our YouTube channel, I believe, is Restorative Wellness Center or Restorative Chiropractic. I'm not sure. One of those, but we're uploading these.
Identity crisis at the moment. We're figuring that one out.
It's one of those, and you'll see our logo. But you can subscribe there, and we are, just getting. We hired somebody to help us kind of make our videos pretty, and we're trying to get them up there as quickly as possible.
It's on me. It's in my to-do pile, and I take full responsibility for it. So we're going to get those up here, last week's and this week's. It's on my to-do list for tomorrow to try to get them sent to the right person and have that happening. So Kate, you'll be able to see this later and share it later. And we appreciate the shares and any invitations to these things. Like I said, the more the merrier. We love doing this, and we want everybody to be feeling free to pass the word along to others who might benefit from some of this information and kind of the informal chat through and being able to answer your questions, because it's about you guys at the end of the day. So
feel free to just give us ideas of other topics that you all are interested in.
Yeah, if you have other topics, send them along as well. The responses have been great. So appreciate everybody, and it's been fun talking thyroid.